So this is the second part of the inflammation talk. So we talked mostly about the cellular and vascular changes and the mediators that help instigate and prolong the inflammatory response. So now let's talk about the pathology of inflammation. So what happens when there is inflammation in the body and what type of responses are there to inflammation? So we'll start with just going through systemic effects of severe inflammation. So this could be a really intense illness. This could be, let's say, like an infection. This could be something chronic, a chronic inflammatory disorder. So general effects of severe inflammation, you don't feel very good. So you feel ill, meaning you don't want to eat very much, you feel weak, and if you're not eating, you can have weight loss. Fever, which again, remember, is when the hypothalamus changes the set temperature of the body so that you have less of a chance to replicate bacteria, and it also encourages the white blood cells to work more efficiently. Increase in very deep sleep. That's what I call the NyQuil sleep. So that's not REM, that's phase like 4 of sleep. So there's no dreaming. It's not very restful sleep for your brain, like when you have deep sleep. So if you've ever just drunk some NyQuil and you wake up in the morning, you like, I don't know where I am or what day it is or what happened. So you're not cycling normally, but that's also when your body's not utilizing much energy. So deep sleep goes up. There is an acute phase protein called C-reactive protein, and it's produced by the liver. So sometimes people think of this as only a liver inflammatory signal, because when you do a test for it, if you find increased C-reactive protein, that can be a sign that there is something like hepatitis, which is severe inflammation of the liver. But the liver makes C-reactive protein in any case that there's severe inflammation. So it's really just a diagnostic tool so that you can detect severe inflammation. There's lymphadenitis, which is inflammation of the lymph nodes generally. So in this picture, we can see enlarged lymph nodes underneath the mandible, the submandibular ones. There's lymph nodes all around the head, down the center of the body, and the lymphatic channels carry all kinds of things, fluids, proteins, fats. But these lymph nodes, they look like lima beans. They have large concentrations of immune cells inside of them. So as things flow through these lymphatic channels, we hope that they flow through these lymph nodes, which will essentially filter out, hopefully, any pathogens so that these immune cells will kind of eat them up. When we talk about antibody is liquid, so we call it the humoral immune system. It's a liquid type of formulation. And when you have a lot of antibody being created, the lymph nodes will also get larger in that case. Lymphadenitis can also refer to an actual infection of the lymph nodes. We'll take a look at that in some later chapters. If you've heard of bubonic plague, that was named that because of buba, or really rubbery, inflamed red lymph nodes on individuals. So the lymph nodes drain areas. So let's say you had an infection, like an upper sinus infection, upper respiratory infection. So I kind of have a little stuffy nose right now. So these lymph nodes underneath the mandible, they drain the mouth, and the pharynx, like the nasopharynx, drains into this area too. So an upper respiratory infection, it's not uncommon to see these lymph nodes swell. So when you look at what lymph nodes are swollen, that's telling you where this infection started, essentially. All right, and then leukocytosis. Leuko is white, cyto is cell, and osis, development of. So you make more white blood cells, which is normal. But if you did a blood count and you saw elevated white blood cells, like in this smear here, you would know that that person is fighting something. They're fighting off some sort of infection. The bone marrow will shift its energy into making white blood cells rather than the normal amount that it typically makes. Usually they're just 1.1% of what's in the bloodstream, and the red blood cells are the majority of the product. So the energy will be shifted into making more white blood cells. Sequela, that's our $10 word of the day. Sequela means the resulting effects of, kind of like the word sequel comes from that. So the sequel, like what's the second part of the story? So sequela are the secondary effects. So we talked about acute inflammation. It's instigated by tissue damage, and it occurs so that these leukocytes, these white blood cells, leave the bloodstream so they can engage in phagocytosis and destruction of whatever the pathogen is. But when there is a lot of phagocytosis, it also damages the tissue in that area, because in order for them to get out, you have to have the vessels dilate, which can change the conformation of the tissues. We'll see some pictures of that. We also know that's good for you, like we want those things to go away, but when you have inflammation, it damages your tissues. The skin can slough off, redness, swelling, and loss of function. We also know that when those vessels loosen up, we have fluid leaving, forming exudate, that fluid formed via inflammation, which is good because it dilutes the pathogen, but you can have a lot of exudate, which swells, and the more swollen an area is, it can be difficult to move that joint or that part of the body. If it's internal, it can actually compress organs and create a loss of function of the organs. Also, the more exudate there is in an area of inflammation, the more it stretches the skin and the more it hurts. So even though acute inflammation is good in the sense that it hopefully removes the pathogen and the ability for further damage to occur, it still is going to damage the tissue depending on the extent of it, which means sometimes we block inflammation therapeutically. And I went through in the last lecture of my very long talk about NSAIDs. So you should know that non-steroidal anti-inflammatory drugs, they block prostaglandin production. And if we sampled from this joint right here, it looks like this person sprained their ankle or hurt their foot. I broke my foot right here a while ago, and they don't do anything. So it's pretty much like this. You just bruised and you can't walk for a while. So when that hurts really bad, remember prostaglandins are derived from damaged cells that have been killed and formed into arachidonic acid. So if we can block prostaglandin production, then we can stop so much swelling. So NSAIDs, they block the cyclooxygenase enzyme to limit prostaglandin production. But remember, all these inflammatory products, they flow through the bloodstream. So like prostaglandins, we can take ibuprofen and limit it. Also remember that antihistamines, like here is Benadryl, we can tell it's Benadryl, or the generic name is diphenhydramine because it is pink, and Benadryl is usually color-coded that way just to build up an association. You'll see that like ibuprofen is almost always brown pills, where like diphenhydramine would be pink pills, so that you generally know what you're taking. Because histamine release is what instigates this, if we block histamine, then we'll block the resulting sequelae of inflammation. So we can block inflammation pharmaceutically by general antihistamines, by blocking histamine release, or by blocking the cyclooxygenase enzyme and prostaglandin production. We can also block that phospholipase A2 that breaks down phospholipids into arachidonic acid by giving steroids. So that could be prednisone, which would be in a tablet formulation typically, or you could give a cortisone shot, for example, right into that affected area. And as I said, these things flow through the bloodstream, which means if you don't want to go the pharmaceutical route, you can start out with the plain old rice principle, resting the area, putting ice on the area, compressing it so that you have less flow through vessels, and then elevating it, hopefully above the heart so that it's now more difficult to get blood there, and then less inflammatory products will mediate the inflammatory response. So cold is a vasoconstrictor, so it tightens up vessels, so there's less products. So that helps limit inflammatory products. But remember, heat, like in fever, we know that heat, it stimulates our immune cells to work more efficiently. So heat stimulates phagocytosis. So there's some instances where patients will be told to alternate between hot and cold. And that's a nice way to get the heat to stimulate phagocytosis and then the constriction and limiting of the extent of inflammation with the cold. So therapeutic modification, your plain old rice, and all of these things are going to try to just reduce the inflammatory products or taking or adding in some pharmacologic means as well. Now let's go through the types of inflammation. And I said exudate is the fluid formed via inflammation. So taking a look at what kind of exudate tells you what kind of inflammation there is. So the first one we have is serous inflammation, which is characterized by serous fluid. So serous fluid is just exudate or transudate. Remember, transudate is clear because it's pushed through a barrier. Exudate is typically yellowish to a little bit not super clear. It's usually yellowish. So this is a burn. If you've seen burns before, this is a very typical pattern of blistering, and you should not pop these, but if you did, you would see that this was a clearish fluid. So that would be serous exudate. Serous exudate forms in the least extent of inflammation, so more minor injuries, and there's not so much widening of those endothelial junctions. So really you're just getting fluid escaping the vessels and going into the tissue spaces, but everything else should remain in the vessel. Clear exudate, you see this in burns, in sores, so in sexually transmitted infections. These types of sores are usually serous fluid. Pericarditis is inflammation of the sac around the heart, which has a variety of causes. We talk about it later. And then there's pleuritis, which is inflammation and exudate in the pleura around the lungs. And the good thing about serous exudate is it's easy for your body to clear it up because there's not a lot in there. It's just fluid. So serous inflammation, most minor form of inflammation, just clear fluid. A difficult type to deal with is fibrinous inflammation. So remember, when you have an injury, we have the inflammatory response, but we also have activation of the coagulation cascade to make clot, and then also to start healing up that area, which means we'll have fibrinolytic or fibrinogenic. We're going to make fibrin, which is the net that forms scar tissue and forms a clot. When there are really large defects, really large injuries, there's an overactivation of fibrin. So fibrin forms scar tissue. And when you have fibrin overactivated, like here is a heart, this person had a pericardial injury, so they've peeled off the pericardium, and the arrow is pointing to these contractures or strictures, which are scar tissue pieces essentially that attach organs to themselves or to each other, but they impede the normal working of that organ. So when there's injury to areas and there's tissue death, fibrin comes around and it can be overactivated, especially when there is damage to an organ, because organs are high in tissue factor, and we'll get to that in a later chapter. But you see fibrinous inflammation with more severe inflammation. Fibrinous exudate is what forms with untreated strep throat, for example. So if the strep bacteria is allowed to keep replicating, you might know that strep throat is associated with cardiac abnormalities. That's because there's an overactivation of fibrin, and eventually it ends up in the bloodstream and ends up on heart valves, and we'll scar those together, like in this picture. It's very complicated to remove this. So in things like endometriosis, in pelvic inflammatory disease, you will see adhesions between like the fallopian tubes and maybe the uterus or the ovaries, and that inhibits ovulation or implantation. So in those cases, they physically cut or remove scar tissue. So it's difficult to heal. Geez Louise, my stuff, everyone's bothering me. All right. You have new blood vessels growing in that area. There's scars. The adhesions refers to things being connected. So when there's, for example, adhesions on a heart valve, there's a new heart valve that's implanted. So it's very difficult to get rid of. So fibrinous inflammation is inflammation plus scar tissue that develops. So you see that a lot in the body. This is a really gross thing, suppurative inflammation. So I said when tissues suppurate, when there's pus in them, then that means there's an active infection. So this individual, so this is obviously their ear, and this is the line of the abscess that they have growing. So just to give you an idea, a cyst is a casing filled with serous fluid. An abscess is a casing filled with purulent fluid or pus, essentially. If the body is able to clear whatever infection is in here, there will still be a cyst that remains with serous fluid inside of it. Ideally, you would want to drain this abscess, but keep in mind, if you drain it, you still have to take out the casing. If you don't remove the casing, it will continue to fill up with serous fluid. So that's important. So suppurative, it's severe injury, and it means that now there's an extra bacterium in there that's causing an active infection. So this is what people call pus, and if you look at the exudate, it's purulent, it's yellowish or greenish, and there's a lot of neutrophils in it, which tells you there's a lot of immunity or inflammation mediation through these white blood cells trying to fight whatever the pathogen is. You see this, so I just mentioned with an abscess like you see in this individual. An abscess essentially just means that there's a pocket of infection inside of a casing. So you want to drain it and then get rid of the casing. This is an interesting disorder. So this person it's called cellulitis, which is an infection of the hair follicle. So we see redness, swelling, inflammation, and the loss of function. In this case, the scalp's job is to have hair follicles growing out of it. You can see that this individual has lost hair in these regions. And we'll get into the type of inflammation this is. This is a type of chronic inflammation where there's granuloma formation, and you physically have to remove the scalp. It's a crazy disorder, but cellulitis that's purulent inflammation, and it spreads pretty rapidly, and you have to physically remove the scalp. Yeah, it's nuts. All right. Hemorrhagic inflammation. This looks like a bruise, but what it is, see the serous fluid here? So here is a cyst. Serous fluid, so clear fluid, and then what you see is there was so much dilation of the blood vessels that not only did white blood cells leave, but red blood cells migrated into the tissue spaces also. So this is very complicated to heal because now there's red blood cells there that need to be broken down. And they'll first be broken down into bilirubin, that yellow substance, and then hopefully cleared from the body. But that is very complicated to heal. This tells you that it was very severe response in inflammation because there was so much dilation of the capillary that the red blood cells got out. So hemorrhagic, that means bleeding inflammation. So it's not a bruise, it's not blunt force trauma causing bruising. This is physical red blood cells that escaped the vessel and got into the tissue bed. Okay, what else? So just so you know, people will use the term itis like appendicitis or these different terms at the same or in the same way that they refer to infection. So here, this is an appendix, and it is obviously inflamed. It's very big. It's very like pussy and gross and red and inflamed. But technically, infection means that there's disease-producing organisms. There's generally a bacteria in there. And in an infection, remember, there is usually suppurated tissue, so it's more pussy. So this is appendicitis, so this was an infected appendix. This is a typical staph infection on the finger, so we see a lot of serous fluid here, and this is essentially made by this bacteria that burrows in there and then destroys the tissue and creates gases, which then puts pressure on this little blister here. This is a very severe infection, we can see because of the color of the exudate. So this is purulent exudate, and this is a lung. So this is a post mortem examination. This person had pleuritis, and there was some sort of inflammation or some sort of infection that colonized the lung tissue. So it was extremely severe. So pretty gross. So just know that itis doesn't mean it's infected, it means that it's inflamed. So we'll use terms like infection only for things that are actively colonized. Okay, the final thing to get through is just chronic inflammation. So there's a lot of chronic inflammatory diseases like Crohn's disease, ulcerative colitis, arthritis, things of that nature. So these inflammatory diseases become chronic when it's 6 weeks of acute inflammation. And chronic inflammation it just starts as acute inflammation. There's some sort of inflammatory response, but the macrophages, so the cells that are supposed to be destroying and digesting the bacteria, they don't remove the agent. And the whole point of the inflammatory response is to prevent an immune response. So in chronic inflammation, you see that immune cells, like here's a T helper cell, are now being activated by binding to these macrophages, these phagocytic cells. And now we have the immune system involved, and now the energy is going to shift into making lots of immune cells and fighting the infection with the immune system. And you can keep that in mind. Pretty much all chronic inflammatory diseases you'll see treated with drugs that suppress the immune response, because as long as the immune response is going, we're going to have activation of inflammation. Chronic inflammation can either be nonspecific, so like in Crohn's disease, it's actually not. In ulcerative colitis, that's nonspecific. In like rheumatoid arthritis, it's nonspecific. It's just chronic inflammation. And if you take a sample at the site of injury, there's a lot of macrophages and also lymphocytes. Lympho means immune, like a lymph node, lymph cells at the site of injury. The other type is granulomatous, which means there's granulomas present. So I said Crohn's disease actually not a second ago. That's because in Crohn's disease, there are granulomas that develop in the small intestine. And what granulomas are like an igloo, like if your body can't get rid of whatever the infectious agent is, it takes skin cells and it makes them really strong and it builds a wall around the infection. It's like, here, look what I made. Now we just have infection in the middle of this. These are really, really tough, so this would not be squishy. It has to be like lanced off. They don't go away on their own, just like scar tissue doesn't go away on its own. There's a lot of scar tissue familiarity here. So if we take a look at a granuloma, so fibrous connective tissue on the outside, so that's your scar tissue. Then you have fibroblast. Blast means cells that create things. They're immature cells. So fibroblasts are cells that make fibrin. And then you've got macrophages that are immune cells that help eat pathogens. These weird cells are called epithelioid cells. Those, whenever you see oid, it means kind of like that. So epithelioid are kind of like epithelial cells, but they have taper ends and they look differently, and they're stronger than epithelial cells. And then at the center, you have multinucleated giant cells that help fight the immune response. But it is a fibrous, so just scar tissue coated factory warehouse of things fighting the infection. It doesn't go away on its own. It does have to be removed. And if you just drained the center of a granuloma, it's going to fill back up again because it has a casing. All things with a casing are like that. All right, so I'm going to post this video online so you can watch it. I'm also going to post a really disgusting picture of cellulitis, so you can see the granulomas, and you can also get an idea of what the healing process looks like. And then we'll talk about that in class. And try not to puke. That would be nice. I also would like you guys to answer these questions for me. I'll read the first one and the second one. Which of the following is an accurate description for the inflammatory phase of wound development? So the inflammatory phase we talked about. Begins soon after injury, is responsible for rebuilding damaged tissues, characterized by redness, heat, pain, and edema or swelling, begins 1 week after the injury, and may last for up to 2 weeks. So I'd like you to find the best answer. There's usually a right answer, or sometimes there's two that are kind of right. There's always going to be a best answer. This is a very typical board question. You have a lot of information that seems really important, like this person was on spring break, they have a UTI, they did a smear of the penis, and there's gonorrhea in there, and that's great. And the only thing it's really asking is release of which of the following chemical mediators is most likely to drive neutrophil exudation. So neutrophils to leave in the exudate. Is it histamine, prostaglandin, Higman factor, bradykinin, or complement? So I'll let you answer that. I also want to point out that if you don't recognize it, sometimes people will pick the answer they don't recognize thinking that they missed something. If you don't recognize it, it means it's not the answer. That's my little hint for you. All right, so that was inflammation part 2, and next will be cancer. All righty.